Sir, I cannot hear you.
सुन रही है प्रीति को?
Yes, sir. So can we start now?
प्रीति जी प्रणाम. प्रणाम.
So good evening, sir.
How are you?
Sir, I'm fine, sir.
Good, great. We are missing you over here.
Sir.
एक प्रीति जब भी आप नैम्स आओगे ना
Yes, sir.
तो we need your help.
Sure, sir.
ठीक है. We need, हमारे एक ड्राइवर है उसको
Okay.
कंसल्टेशन चाहिए, काउंसलिंग चाहिए, but he doesn't
ठीक.
want it from a psychiatrist because
Okay.
he belongs to a village background.
Acha, I understand.
You can understand all the things. चलिए.
Good evening, sir.
सर मैं कपिल बोल रहा हूँ सर.
हाँ, गुड इवनिंग.
तो गुड इवनिंग सर. वो 25 तारीख के लिए कंफर्म कर दीजिए. वो बेचारे अपना इनॉग्रेशन
ऑन वर्चुअल है ना?
हाँ सर.
डन एज यू एडवाइस. डन.
नहीं मैं क्या एडवाइस करूँगा
नहीं
सर?
नहीं आपके
मेरा वो बेचारे बड़े परेशान हो रहे हैं राजेंद्र सर.
25 तारीख को. डन.
ठीक है सर.
आकाश, नाइस सीइंग यू एंड नाइस सीइंग निपुन.
Sir, good evening.
Everyone, thank you.
Good afternoon, Dr. Akash. Good afternoon, Dr. Umesh.
Good evening, Nipun.
Sir, how are you, sir?
Good.
So we start in another minute or so, Preeti?
Yes, sir.
Yes.
Okay, all right.
So good evening, one and all. I welcome you all to today's Navigate Medico CME program. So I'd like to now request Mr. Professor Umesh Kapil sir, the Secretary of National Academy of Medical Sciences, to provide his welcome address.
Namaskar to all of you and greetings from National Academy of Medical Sciences. It's a proud privilege to welcome our respected Ajay Dusija sir, who has been helping us for last 3 years in many program activities related to liver diseases. As you all know, we have a series of lectures on management of common liver disorders. And today we have Dr. Nipun Verma, Associate Professor, Department of Hepatology, PGI Chandigarh, to deliver a session on management of infection in cirrhosis. This is a very important area in which lots of new knowledge have come in recent years. My special welcome to Professor Akash Shukla sir, who is the Professor and Head Department of Gastroenterology at State Medical GSMC and KEM Hospital, Mumbai. With these few words, I again welcome all of you on behalf of NAMS. And over to you, Dr. Preeti. Dr. Preeti is an Assistant Professor in Department of Psychiatry at All India Institute of Medical Sciences. And she has volunteered herself to be a master comparer for this, all the sessions which we are doing through Navigate program. Preeti ji, you're also most welcome and thank you very much for joining us. Thanks a lot.
Thank you very much, sir, for the opportunity, and thank you very much, sir, for the valuable initiative for the PG students. I would now like to request Professor Sivsarin sir, the President of National Academy of Medical Sciences, and also the Director of our WHO Collaborative Center on Chronic Liver Diseases and Viral Hepatitis, ILBS, to provide the remarks for the Navigate Medico CME program.
Yes, Navigate CME is an initiative of the NAMS. This is the National Graduate Medical Virtual CME program. And the need for such a program arose when we talked to people who said, oh, we want to learn from such and such giant, such and such iconic teacher, such and such person with clinical experience. And with that in mind, we have tried to collect and take time from the best teachers, knowledgeable experts in the country in different fields. And we would like to therefore thank Professor Duseja, who is the head of hepatology at PGI, and his team for having provided us with excellent speakers, and also Professor Akash Shukla, a very eminent gastroenterologist from GS Medical College, Mumbai, and KEM. The idea is that the residents, fellows who are appearing for exams for maybe their MD, MS, DNB, would enjoy, talk to them. This is an interactive session, and we would like to people to shoot questions, be interactive. And I must say, one of the best things today is that a youngster like one of you, Preeti, is Dr. Nipun, who is not only a very good hepatologist, but also an excellent person on machine learning and also on artificial intelligence. With that, I thank Dr. Kapil, Dr. Ajay Sood, and the whole NAMS team for having made it possible. But please join, please interact, and learn together. Thank you. Over to you, Preeti. Please unmute.
Oh, thank you, sir. Now I'd like to invite the Chief Coordinator for the today's CME, Professor Ajay Duseja, sir. Professor Ajay Duseja, sir, is the Professor and Head, Department of Hepatology at PGI Chandigarh. He's also the Secretary General at the Indian National Association for Study of the Liver, and his chief research interests includes non-alcoholic fatty liver disease, ACLF, viral hepatitis, and hepatocellular carcinoma. He has more than 325 publications, including 27 chapters and books, and he has multiple awards, including the Dharamveer Datta Memorial Oration Award from the prestigious Indian Council of Medical Research. It's an honor to have you with us here, sir. Over to you, sir.
Thank you, Dr. Preeti, for that very kind words and introduction. And at the outset, again, my sincere thanks to NAMS, Professor Sareen, Professor Kapil, Professor Sood for giving us this opportunity, for taking the burden and the how to handle the liver disease to our youngsters. And the topics we have chosen are those which we thought are of real everyday interest to most of the youngsters. And we also understood that the major killer in liver disease or chronic liver disease are the infections, and Dr. Nipun has really done a very good work on infections and cirrhosis, and we thought that no better person can him be the speaker for today for infections and cirrhosis. So my thanks to him also for agreeing to be the speaker. My special thanks to Dr. Akash Shukla for moderating this session, who's the head at KEM, and he has done again extensive work in hepatology in journal and cirrhosis and infections in particular. So thanks to you, Professor Akash, as well. So over to you for the next thing. Thank you.
Thank you, sir. Now I'd like to invite the chairperson for today's CME, Professor Akash Shukla, sir, who is the head of the Department of Gastroenterology at SET GSMC and KMH, Director of Hepatology at Sir Hutchin Reliance Foundation Hospital. He has multiple key achievements, including he is a member of the Baveno 7 guidelines for portal hypertension management. He has authored the APASL guidelines on Budd-Chiari syndrome and has been part of 6 international and 10 national guidelines. He is a member of the steering committee of Vascular Liver Disease Interest Group and EASL, which is the first and only non-Europeans ever. He had been an author of 3 textbooks and 8 chapters, and he is a nodal officer for Center of Excellence at Chem Hospital for Management of Rare Diseases, and he is a TRG member of National Viral Hepatitis Control Program under Government of India and NVHSP under Government of India. He has multiple awards, including International Achievers Award in Dubai 2017, Young Gastroenterologist Award at GIFCON in 2018, Plenary Award in APASL 2018, and he has more than 100 publications to his credit. Now I would like to invite Professor Akash Sukla sir to kindly introduce the speaker and chair the session. Over to you, sir.
Thank you so much, Dr. Preeti, for those kind words of introduction. I'd like to thank Dr. Sareen sir and Dr. Ajay Duseja sir for giving me this opportunity. Many of these achievements are thanks to them. So at this stage, I would want to welcome Dr. Nipun Verma, who is the Associate Professor at Department of Hepatology at PGI Chandigarh. He is a clinical scientist and faculty from PGIMR. He's trained in hepatology and transplantation from PGI Chandigarh and Pittsburgh, USA. He has been awarded with 7 gold medal and silver medals in undergraduate and postgraduate career. He's a member of the ASLD, EASL, INASL, ACG, BSAC, and the Microbiology Society of UK. He was awarded the BMJ South Asia Finalist Award 2018, Major Amir Chand Gold Medal Award in 2018, Award for Best Research by PGIMR in 2019 and 21, and Best Researcher Award at the 9th International Scientist Award on Engineering, Science and Medicine in 2021. He has more than 100 publications and chapters to his credit and has conducted 10 projects as PI and 8 projects as co-PI. He is also Assistant Editor of Journal of Clinical and Experimental Hepatology. His areas of interest and research include liver failure, infections, multiomics, artificial intelligence, telemedicine, and evidence-based medicine. He is a core committee member of Center of Excellence, Artificial Intelligence in Healthcare, PGIMR Chandigarh, and Communication Skills for Residents. His clinical duties include management of liver, pancreas, and biliary tract disorders, including endoscopic procedures and medical aspects of liver transplantation. And he's going to discuss today management of infections in patients with cirrhosis. So it's over to you, Nipun.
Thank you very much, sir. Can you see my screen?
Yes, we can.
Okay. So many thanks to the NAMS, Professor Sareen, Professor Kapil, and Dr. Sood, and Dr. Duseja, and esteemed panel and my colleagues for joining me here. I bring greetings from PGIMR Chandigarh. So today I'll be speaking on diagnosis and management of infections in cirrhosis, where the science and art both meets together, and we can help our patients to improve their outcomes. So briefly, over the next 60 minutes, I'll be taking you through the introduction to the concept of infection and sepsis, pathophysiology of infections, what are the pillars of management, and take-home messages. So first, we need to understand why patients with cirrhosis is different from other medical population. Patients with cirrhosis have a distinct pattern of immune dysfunction, which increases the risk of infection in these patients. The overall incidence and severity of infections is high in patients with cirrhosis and nearly 4 to 5 folds higher than patients without cirrhosis. The risk of MDR infections are quite common, and their mortality is close to 70 to 75% in patients with cirrhosis, as opposed to 40 to 45% in other medical population. End organ damage due to different organ failures is higher in patients with cirrhosis, and this is likely due to altered sensitivity of the organs in these patients. And these infections often precipitates the liver failure, leading to acute on chronic liver failure in these patients. Often delays in diagnosis and treatment results in higher mortality, more so in patients who are in hypotension. Fungal infections are increasing, and they have an exorbitant mortality in patients with cirrhosis as opposed to other medical population. And viral infections are often underdiagnosed and undertreated in patients with cirrhosis. So all in all, patients with cirrhosis behave poorly as opposed to general medical population. Therefore, there is a unmet need for identifying these patients with infections at the outset. If we look at the global epidemiology of infections in cirrhosis, there is a recent paper published in 2019 where multi-centric data was collected all throughout the world. And in India, the maximum data was there from Institute of Liver and Biliary Sciences and PGI-MER Chandigarh, where nearly 250 patients were recruited. And we could see that the overall prevalence of infections was near about 30%. But the range in literature is close to 25 to 60% of individuals with cirrhosis at admission or during hospitalization are found to have infections. And these infections are predominantly related to bacteria, followed by fungal infection and followed by viral infections. If we look at the prevalence of infections, the rate of infections increases as the patient's hospital stay increases, and more so in patients who are in multi-organ failures as opposed to patients who are completely stable. Infections lead to high risk of organ failures and mortality, and the reasons for the same we'll be looking in the subsequent slides. Overall, the risk of multi-drug resistant bacterial infections are increasing in patients with cirrhosis because of a lot of invasive procedures, repeated hospitalizations, and antimicrobial prophylaxis. And these group of infections, because of multi-drug resistant bacteria, often leads to poor response to antibiotics. Empirical antibiotics fail, and these patients often develop septic shock, increased cost of stay, and these patients have very high risk of mortality. And if we look at the global prevalence of multi-drug resistant bacterial infections, India tops the list globally, and it is close to 70% of all microbiologically proven isolates are shown to be multi-drug resistant infections in cirrhosis. And if we look at the outcomes of these patients in cirrhosis, we see that there is a fourfold higher mortality in patients who have cirrhosis with infections as opposed to patients who do not have infections. So infections increases the odds of mortality by fourfolds. So what happens when there is an infection in patients with cirrhosis? There is a circulatory dysfunction ongoing in patients with cirrhosis because of portal hypertension. Because of portal hypertension, we saw in the first lecture of this series by Dr. Sahaj, who beautifully showed that there is a splanchnic vasodilatation followed by cardiac dysfunction in these patients with cirrhosis. And there is an exaggerated response to an infectious pathogen in patients with cirrhosis, which leads to systemic inflammation, which deteriorates the hemodynamic aspects of cirrhosis and also derails the immune functions in these patients. And the conglomerate of both these axes leads to multi-organ failures, especially kidney organ failure, and can precipitate hepatorenal syndrome, the pathophysiology of which is based on the renal vasoconstriction. And the other organs, especially the infections, can precipitate the bystander hepatitis or increases the inflammation inside the liver, leads to jaundice and coagulopathy. In brain, it can precipitate encephalopathy. Adrenal glands, it can increase the risk of adrenal insufficiency, and further it adds to the gut ischemia, leading to translocation of bacteria and endotoxins. Infections can, as you know, that infections can precipitate multi-organ failures. And the multi-organ failures has been taken into the consideration of acute on chronic liver failure by European group. And they defined acute on chronic liver failure depending upon the number of organ failures. 2 or more organ failures were classified as ACLF grade 2, and 3 or more organ failures were classified as 3. Whereas grade 1 ACLF was defined when there was single organ failure, either kidney, or if there is non-kidney organ failure, then the creatinine has to be 1.5 to less than 1.9. Or there is a cerebral failure with a creatinine of 1.5 to 1.9. So why I'm telling you this is because the number of organ failures determine the patient outcomes. And the organ failures have been taken into the consideration by European people. And if you look at the prevalence of infections in patients with acute on chronic liver failure, a beautiful study from AIIMS New Delhi by Dr. Shalimar's group showed that bacterial infections are present in near about 10% of individuals at admission. And if we follow them up during the hospital stay, they develop infections in near about 74% of patients. So ACLF per se is precipitated by infections, as well as in patients with ACLF, there is a very high risk of acquiring infections. And if you look at the mortality of these patients who are infected with they have a very high mortality of 75%. So before we move ahead and look at the different aspects of management, let us clear our concepts of infection. So when do we say a patient is infected? If you look at the axis of infections, when pathogens breach the normal barriers and reach into the circulation or a local site and incites a local inflammation, which is clinically apparent, this syndrome or this conglomerate of signs and symptoms is called infection. And if we see that the textbook definition of infection is invasion of a normally sterile body tissues by disease-causing organisms by their multiplication and reaction of their host tissues to the infectious agents and the toxins they produce. Mind you, that the infection has to have a two component, one, breach of barriers, followed by the immune response, which is pathological and which is clinically apparent. For an example, a candida colonization in gut with a local inflammation is not an infection, whereas patients who have a candida colonization followed by an aberrant immune response causing organ failure is an infection. Let's say, see when this infection, the local breach of barriers by a pathogen reaches the systemic circulation and circulates throughout the body and leads to systemic inflammatory response. And this systemic inflammatory response is defined by the operational definition of SIRS. And we all know what is the definition of SIRS. We define SIRS by two or more of the following criteria: the temperature of more than equal to 38 degrees or less than 36 degrees, with a tachycardia, tachypnea, or elevated or low WBC counts. When this systemic inflammation becomes haywire, there is a preponderance to develop organ failures and organ dysfunction. And this state where there is organ dysfunctions, which is operationalized by the definition of rise in SOFA scores by more than equal to 2 points, is called sepsis. And the typical example of infection being bacteria invading into the circulation causing bacteremia is called an infection. When it leads to a systemic inflammatory response, it is called SIRS. And when it leads to organ failures, it is labeled as sepsis. The definition of sepsis has evolved over the years. Initial definition of sepsis was a simple definition of systemic inflammatory response to a pathogen, where it was defined as fever, tachycardia, tachypnea, and leukocytosis. However, it was non-specific and non-sensitive because patients with liver cirrhosis, when get acute hepatic damage, can lead to systemic inflammatory response, and all these patients will have systemic inflammatory response, and these patients are often get confused with the infection. So this is a non-specific definition for sepsis in patients with cirrhosis. Then came the definition of sepsis as sepsis 2 definition, which was defined based on the PYRO model. And the PYRO model was defined as a predisposition where cirrhosis patients and sarcopenia in cirrhotic patients have a high predisposition to get infection. And when these patients get infected with pathogen, it is constituting the state of injury. Then there is a systemic inflammatory response and there are organ failures. But how to operationalize this definition for real world management and diagnosing patients with infections in cirrhosis is quite cumbersome and too complex. Therefore, and more so in other medical patients also. Therefore, this definition was dropped. And recently, 2021, they came up with the definition of sepsis 3 definition of sepsis, where they showed that and it's a consensus-based definition where they defined sepsis as immune dysregulation to a pathogen and causing organ dysfunction. And organ dysfunction in patients with cirrhosis is defined by Cliff SOFA scoring system. And everybody should be aware of the organ failure system in patients with cirrhosis, where the liver failure is being defined as bilirubin of more than equal to 12, a kidney organ failure, which is defined by creatinine of more than equal to 2 milligram per deciliter. Cerebral or CNS failure is described based on the grade of encephalopathy they have, if there is a grade 3 or more encephalopathy. Coagulation failure is defined based on the INR levels more than equal to 2.5 or a platelet count of less than equal to 20,000. Circulatory failure is defined as a low MAP requiring any vasopressors, and the lung failure or the pulmonary failure is defined based on the PO2 FiO2 ratio of less than equal to 200. And if there is no PO2 available, you can also use saturation of the patient, and the saturation or divided by the FiO2 less than 214 is defined as respiratory failure. So any patient who has a rise in SOFA score by more than equal to 2 points from the baseline is defined as sepsis in the presence of infection. So infection plus organ failures is defined as sepsis in patients with cirrhosis. And if you look at the pathophysiology, how pathogens causes derailment of immune system, before we move ahead in cirrhotics per se, if we look at the evolution of models of sepsis in general, the initial concept of sepsis was followed by infectious pathogen entry. There is a systemic inflammatory response, and exaggerated systemic inflammatory response can lead to death in these patients. However, over the time, we realized that apart from systemic inflammation, there is a lot of anti-inflammatory response is also developed in the body. And this is called compensatory anti-inflammatory response. And then there is also a stage of mixed anti-inflammatory response. So this concept also came, but this was also rejected because people also found that, during the early phase of inflammation, there is also anti-inflammatory molecules present inside the blood. So they also found that the immunosuppression was present at the outset of sepsis. So therefore, the concept of concomitant pro and anti-inflammatory responses in a given individual came. And this concept suggests that in the early phase of exaggerated inflammation can lead to inflammatory damage, or TNF-mediated cell death in infected patients can lead to immunopathological damage. But also, if there is an exaggerated anti-inflammatory or immunosuppressive phenotype, then these patients can develop secondary infections, and then these patients can die because of uncontrolled secondary infections. And then there is also a state of persistent inflammatory catabolic state in patients who survive the acute episode of infection or infection. This state has been defined in general population of sepsis, where it is shown that these patients have severe mitochondrial dysfunction, energy dysmetabolism, and severe sarcopenia, which again leads to high risk of infections and poor outcomes in general sepsis patients. So how do this concept of sepsis, which has evolved over the period of time, applies to patients with cirrhosis? If we look at the patient's natural history in cirrhosis, they progress from a stage of compensated cirrhosis to decompensated cirrhosis to acute on chronic liver failure. What happens in the early phase of cirrhosis is that whenever there is an inciting agent, more so pathogen, if it enters into the portal circulation or in the Kupffer cells, there is a pro-inflammatory response. There is a lot of production of interleukin-1, TNF-alpha. Apart from that, there is a concomitant anti-inflammatory response which takes care of this pro-inflammatory response, and patients remain in the state of dynamic homeostatic variability. However, when the patients become decompensated, that is, they develop ascites, they develop bleed, they develop encephalopathy, this inflammatory response becomes uncontrolled. The systemic inflammation becomes uncontrolled, and the anti-inflammatory response is not able to control this inflammation. And this pro-inflammatory response causes immunopathological damage. However, as the stage progresses and these patients progress on to develop organ failures, there develops a state of immune exhaustion. And this immune exhaustion is because of so many factors, because of the cells, because of cytokines, because of immune checkpoints. Because of all the things, these patients are not able to clear the damaged, damage associated molecular patterns as well as the pathogens from the body. And these patients have a poor response to infections. So these patients develop infections, secondary infections, and immunodeficiency prevails in these patients, and they die because of secondary infections. So how this concept of immune dysregulation fits into the sepsis phenotype, which we saw in the previous slide. So in patients with cirrhosis and ACLF, there is a similar pattern of immune dysregulation as we see in patients with sepsis. So it is very difficult biologically as well as clinically to differentiate or segregate patients with infections and without infections in patients with liver failure. However, on the subsequent slides, we will see how best we can do, how best we can approach these patients and treat these patients early on to prevent and death, prevent mortality and organ failures in patients with infections and cirrhosis. Again, coming to the basic facts first, why patients with cirrhosis have a high risk of infection. The ascitic fluid protein is one of the important factors which increases the risk of infection. Why? Because when the ascitic fluid protein counts are protein levels are less than 1 or 1.5 gram per deciliter, these patients have a very low complement activity in their ascitic fluid. So any pathogen which is invading the portal circulation and going into systemic and seeding into the the lymphatics of abdomen, they are poorly cleared by patients with cirrhosis as opposed to patients who are not cirrhosis. So patients with cirrhosis have with ascites with low protein levels have a very high risk of development of infections, and this is the basis for using certain prophylactic agents in these patients, and I'll come on to that thing also. Patients who have a very poor liver dysfunction, who have a very high MELD score, they have a poor immune functions. So these patients have high risk of infections, and bleeding per se increases the risk of infections because of gut ischemia, increased translocation. That is the clinical factors which predispose to infections in patients with cirrhosis, and more so repeated hospitalization, ongoing prophylaxis, which we use many a time in patients with cirrhosis. With ascites, we use SBP prophylaxis. So these patients get colonized with MDR bacteria, and this also increases the risk of infections in patients with cirrhosis. So a lot of clinical factors, amongst them the most important being the severity of cirrhosis, the bleeding, and the ascitic fluid protein. These are the most important factors clinically which we see day in and out, which can predict the risk of infection, and that we can use in a clinical practice to stratify the patients that yes, this patient can be at high risk, more stringent follow-up is required in these patients. Then there are certain genetic factors, the polymorphisms in the pattern recognition receptors on the immune cells can also predispose, the gut dysbiosis, the barrier failure. A lot of immune dysfunction goes on in patients with cirrhosis and at the level of gut. More so, there is a lot of data coming up on the mate cells, which is out of context, although and there is a lot of data coming up in cirrhosis associated immune dysfunction, which increases the risk of infections in cirrhosis. So a lot of crosstalks happen, and if we just look at the three key aspects of pathophysiology of infections in patients with cirrhosis, one is dysregulated immune response, second, altered hemodynamics, increase in portal pressures, and third is the organ maladaptation, which happens because of metabolic failure, more so because of mitochondrial failure in these patients with cirrhosis and infections. And all these three key axes predispose to multi-organ leads to multi-organ failures and mortality in patients with cirrhosis. Any very important thing which one need to understand is that why a certain patient with infection progress on to develop sepsis. It is due to the impaired tolerance of host to infection, which leads to sepsis. And what is this impaired tolerance? This impaired tolerance is related primarily to altered heme metabolism. There is a lot of free radical generation because of ferric ions. Transferrin is low. There is dysfunctional ferritin. Gluconeogenesis is impaired, and there is mitochondrial dysfunction, which leads to a lot of oxidative damage, leads to progression to sepsis in patients with cirrhosis, loss of muscle mass, lower body temperature in patients with cirrhosis, dysfunctional control over inflammation, and impaired phagocytosis. All these conglomerate of findings, leads to progression to sepsis in patients with cirrhosis. And the independent predictor of organ failures are a specific group of infections, which will be coming in the subsequent slides. Unfortunately, over the period of time, if we see the risk ratio or the risk of mortality due to infections in cirrhosis has not improved, although other complications like hepatorenal syndrome and GI bleeding, with the advances in the management, their incidence or the risk ratio is decreasing over the time. But the sepsis remains very high on the cards for the risk of mortality in patients with cirrhosis. And that is because there is a lot of multi-drug resistant bacterial infections which is coming up in these patients, which is associated with lower resolution of infection, higher incidence of septic shock, organ failures, and short-term mortality in patients with cirrhosis. So if we look at the different pillars of management of infection in patients with cirrhosis, the four key components where one has to consider and treat patients with infection is, first and foremost, is to make a diagnosis early on and treat these patients with infection, manage their fluids, vasopressors in patients who are hypotensive, and adequate nutrition. Early and appropriate treatment improves the outcome in patients with infections, in patients with cirrhosis. And there are two syndromes described by European group. One is acute decompensation, and one group is called acute on chronic liver failure. Acute decompensation is defined by European people as development of ascites within a span of 2 weeks, or worsening of previously well-controlled ascites, development of encephalopathy, development of variceal bleed, or development of infection. Any acute decompensation, if associated with organ failures, is defined as acute on chronic liver failure. And in these patients with acute decompensation or ACLF, if there is an adequate empirical antibiotic being given, the mortality is lower as opposed to patients who are given inadequate antibiotics. And this is a study published recently, a PREDICT study in Journal of Hepatology 2021, where both acute decompensated and ACLF patients, if given adequate antimicrobial therapy early on, then the outcomes are quite better. And in patients with cirrhosis who have infection in SBP, which is called infection in the ascitic fluid, and if they have shock, any hour delay or each hour delay of antibiotic leads to 1.8 times higher incidence of mortality. So patients need early treatment, early diagnosis for infections in patients with cirrhosis. So how do you suspect infection in patients with cirrhosis? History and examination are the key pillars of diagnosis, and patient's trajectory is the second most important criteria. The clinical criteria includes, this is no brainer that presence of fever points us toward the infection, but there are many other causes of fever as well, and one need to consider non-infectious causes of fever. But most of these patients have infections. If we see out of 100 patients, cirrhotic patients with fever, majority 80 to 90% would have infection. Development of acute decompensation, that is worsening of previously well-controlled ascites, worsening of encephalopathy, development of upper GI bleed, which are the criteria for acute decompensation. Any patient presenting to us with worsening, one should consider infection and rule out infection before moving ahead. And that too more important in patients who are coming to us in OPD. Development of organ dysfunction, and organ dysfunction, which we have previously classified based on Cliff-Sofa score. We can also see each organ individually and see if there is more than equal to 2 points worsening in any organ failure, then one must consider infection and rule out infection. Development of encephalopathy, site-specific symptoms and signs of infection. Every patient who comes to us in OPD with decompensation, we look at different signs and symptoms specific to gastroenteritis, development of a particular skin and soft tissue infection, etc. Development of bleed, worsening of ascites, development of renal failure. So any organ dysfunction in a patient with cirrhosis must consider infection. Additional risk factors and the history which we have to take is the travel to endemic area, prior contact with the healthcare facility, invasive procedures, antibiotic prophylaxis, and prior episodes of SBP if these patients have. And then examination can show features suggestive of the tachycardia, tachypnea, which is features of SIRS. Development of organ dysfunction such as hypotension, any sign and symptom particular of infection like cellulitis or wounds, crackles on chest examination, abdominal tenderness, and paravenous sinus tenderness. The working definitions of infections, there is a lot of infections in the definition of infections in literature. If we closely look at the definition of infections per se in cirrhosis, is not different, apart from few important infection, which is very peculiar to cirrhosis, which is called spontaneous bacterial peritonitis. And working definition is ascitic fluid neutrophil count of more than equal to 250 per cubic millimeter without any evident intra-abdominal source. And perhaps the definition, which is monobacterial, it is likely, and culture negative neutrocytic ascites is often described when the cultures are negative. Culture positive SBP is also defined as typical SBP, and a patient who has a ANC count of less than 250 but bacteria in the ascitic fluid are called bacteria ascites. And these are the different definitions of SBP defined by American group in American guidelines. Apart from other sites of infection, it is similar to general medical literature, where UTI is defined by one or more symptom and sign of urinary tract infection with positive urinary culture. If there is no urinary culture positivity, then urinary pus cells or dipstick can be taken into consideration, but patient need to have at least 2 signs and symptoms. And pneumonia, one must have at least 3 different findings: 1 on imaging, 1 on local sign and symptom, and 1 on the systemic sign and symptom. And for bloodstream infection, if the blood cultures are showing a non-common skin contaminant, and if 2 or more blood cultures, then it is 2 or more blood cultures for a common skin contaminant like coagulase negative, staphylococcus, diphtheria species, etc. So a patient who comes to us for suspected infection, we do a lot of workup for infections, and that should include hemogram for leukocytosis, peripheral smear for toxic granules, urinary microscopy for the neutrophils and the casts, ascitic fluid cytology for neutrophil counts, the proteins for ruling out tuberculosis, and high protein for tuberculosis, and cytology and ADA. And ADA is for tuberculosis, and the cutoff is 20 to 25 has been described in literature. Different cultures from the suspected site of infection. Chest X-ray and radiology is very important when we are suspecting infection, especially in the chest or in the other sites, especially osteomyelitis if we are thinking. Biomarkers should be done carefully and needs diagnostic stewardship in these patients, and procalcitonin is one biomarker which is commonly used in hospitalized patients for diagnosing as well as monitoring patients for infections. And I will be coming to these biomarkers. And arterial blood gases with lactate, and rectal or nasal swabs for colonizing bacteria. Again, this is also an area of active research. So what are the factors which govern the treatment of infections in patients with cirrhosis? So there are 3 factors which help us in making antimicrobial decisions and follow-up care of patients with infection. First is the pathogen level factors, which includes the type of organism, whether it is a gram-negative, gram-positive, or is it a risk? Is it an MDR? And MDR is defined by at least resistance to the antimicrobial categories in at least 3 or more categories is defined as multi-drug resistant bacteria. And the kind of inoculum and virulence of a pathogen is also an important factor in defining the treatment. The inoculum, I mean that a patient who's having pneumonia or a bloodstream infection has a very high load of bacteria in a human being, as opposed to patients who have a lower urinary tract infection, or a patient who has a cellulitis, local cellulitis without any systemic sign and symptoms. So an inoculum determines the dose as well as the duration of antimicrobials in patients with infections in cirrhosis. If a patient has a highly virulent infection, that again, patient needs a higher dose and a longer follow-up or treatment of these patients of infections. The host level parameters which define or govern the use of antimicrobials and duration is the severity, and this is the most important out of all factors governing the antimicrobial treatment. The severity of infection, that is the patient who has a shock, a patient who has an organ failure, has a very high risk of mortality, and these are the patients, high risk patients, especially who need early treatment, appropriate, adequate treatment for prevention of their mortality. Disease severity, that is their liver disease severity, the MELD score. If the patient has a very high MELD score, then the patients have a high risk of acquisition as well as mortality. So these are the group of patients also who merit a close, workup for infection. If there is an ongoing immunosuppression, let's say a patient with alcoholic liver disease who has been given steroids for alcoholic hepatitis, as we saw in the last presentation, and these patients who are on steroids or immunosuppression for any other XYZ disease has a very high risk of infection. Again, the trigger for suspecting and diagnosing infections is very low. Genetic predisposition, which as of today we don't have very strong lab parameters as of now, but a lot of research is going on in pattern recognition, receptor polymorphisms, and then the post factors including the pharmacokinetic and pharmacodynamic changes because of the antimicrobial use related to antimicrobials is governing the dose and duration of antimicrobials in patients with infections. Environmental factors, yes, definitely it is very important. The setting of infection, community acquired healthcare or nosocomial, because the nosocomial infections have a very high risk of multi-drug resistant bacterial infection, and therefore our empirical treatment of antimicrobial should be based on the setting of infection. And the regional epidemiology is the very important factor in governing the treatment. And out of all the factors which I have told you, the severity and the regional epidemiology is the most important for governing our early empiric antimicrobials, and then following up these antimicrobials with the cultures. If we look at the rate of multi-drug resistant bacterial infections in India, it is 70%, as I showed you. And if we, in this table, I have summarized actually all the epidemiology of infections in India as opposed to the global estimates. We see that all the estimates are higher. Indian patients have a higher prevalence of infections, whether it be AD patients or whether it be ACLF patients. If we look at the MDR rate, 73%, XDR rates is 33%. The nosocomial infections are higher. Most so they are because of gram-negative infection. Gram-positive is near about 30%. E. coli, Klebsiella, gut origin bacteria are commonest. The MDR bacteria are Enterobacteriaceae, and carbapenem-resistant bacteria are the commonest. And community-acquired setting, the rate of MDR is quite low, and predominantly nosocomial. All nosocomial infections are multi-drug resistant. Therefore, our empiric antimicrobial decisions should be tailored according to the setting as well as the severity of infection. And if we look at the rate of MDR bacteria, the bacteremia are commonest, and pneumonias in our setup, at least in PGI, we have a very high rate of MDR infections, and the mortality of MDR infections is higher in India as opposed to the global estimates. And if we look at how to diagnose these infections, apart from clinical and the examination, we have a lot of biomarkers which can help us in defining infections. So there is a clear end of spectrum where we have a definite criteria, we have a culture positivity. There is no doubt that there is an infection in these group of patients. And then there is a group of patients who are clinically stable, they are not worsening, they don't have any systemic signs and symptoms. They are also very clear. But there is a very big gray zone near about 50% of individuals with cirrhosis who are admitted in the hospital, in whom we are most of the times not clear whether there is an infection or there is absence of infection. There, the role of biomarkers is emerging, and if we look at if you combine multiple biomarkers, we increase on the specificity of ruling in the diagnosis of infections, and if we look at the specific biomarkers, the CRP is one which can be used for ruling in or ruling out the diagnosis of infection. More importantly, for ruling out, and but one need to understand that it can be falsely negative in patients with cirrhosis because liver does not produce C-reactive protein in some of these individuals, so it can be false negative. But it has been defined in literature as a rule out criteria. Procalcitonin has been used for diagnosing, for monitoring, and for stopping treatment of infections in cirrhosis. There is no good randomized controlled trial to support the use of procalcitonin, but depending upon the level of liver dysfunction, depending upon the level of bilirubin, the levels of procalcitonin are also being described, because procalcitonin is a kind of biomarker, acute phase reactant also, which is released by any type of cells in the body, and the cutoff of 0.9 has been described for a bilirubin of more than 20. One need to understand that it can be elevated because it's because of sterile inflammation, bacterial translocation. And if we combine both PCT and CRP, it increases the sensitivity and negative predictive value, but the role of combination is again debatable, and there is no good RCT. Lot of emerging biomarkers, pre-sepsin has been described, but not shown superior to PCT in a study. RT-PCR based, which is a conventional PCRs or the real-time PCR based particular panels like BioFire has been described for diagnosing infections, specifically the genetic DNA of these infection, these bacteria, and which is rapid, which can have very high sensitivity and specificity. But the problem is that it is expensive and need good equipments and in the setup also. And there are a lot of evolving biomarkers. MALDI-TOF directly, which is a specific technology where we can, identify bacteria as early as possible in the culture plates. Using MALDI-TOF is a matrix associated, deionizing technique, time of flight technique. And then there are a lot of biomarkers such as neutrophil related CD64, and then lipopolysaccharide binding protein, CD60, 160. So all these things are under research and yet to be available at secondary care or tertiary care level at most of the centers. A lot of emerging data on microfluidic based and sepsis score, but I need not to go into these details. Real world challenges more so in patients with cirrhosis include SIRS can be due to sterile inflammation, lot of confounders of infection because X-ray can show infiltrates because of volume overload, because of collapse, because of bronchial obstruction. One need to exclude all these factors. And again, there is an art of diagnosing infections more so when there is a science in these patients. And the organ failures can happen because of because of sterile inflammation, because of alcoholic hepatitis or HPV flare. So one needs to consider all the confounding factors before making a diagnosis. So let's say a patient comes to us in hospital, and we look at their clinical profile, and if we look at their organ failures. Let's say a patient has 3 out of 1 criteria, which is called Q-SOFA criteria. If the patient has a altered mental status, increased respiratory rate more than 22, or has a BP of less than equal to 70. Any 2 out of these 3 criteria, these patients are at high risk of sepsis. I'm saying at high risk of sepsis, not sepsis. So these patients needs to be admitted into the ICU, and these patients need appropriate care in the ICU. If the patient has a baseline SOFA score available, and if the SOFA score worsens more than equal to 2 points, again, these patients have a poor outcome and should be considered to be transferred to ICU. So if the patient do not have Q-SOFA or less than sepsis 3 criteria of more than equal to 2 points, then these patients can be managed on OPD basis. Algorithm was provided, proposed by us in recent articles, where we showed that, if there is a presence of shock or multi-drug resistant bacterial infections, risk of MDRO is high based on the certain criteria, then these patients should be covered up with empirical antibiotics with gram positive, with carbapenem cover. And if there is no risk, no shock, or risk of MDRO is low, then one must look at the site of infection and treat these patients according to the site of infection. Risk of MDRO, as previously mentioned, that the Indian patients already are at very high risk. Nosocomial acquisition of infection or healthcare associated infections in Indian setup are at high risk. Disease severity of MELD score of more than equal to 20 or 30 in some series have shown that they are at high risk of MDRO. If the patient has received broad spectrum antibiotics in last 3 months, patient has undergone any invasive procedures such as invasive biopsy or tapping or TIPS, patient has a specific infection such as pneumonia or the patient is on norfloxacin prophylaxis is also considered as a risk factor for multi-drug-resistant infection. Gram-positive infection we must consider in patients who have a nosocomial acquisition, who has a long hospital stay, who has multiple lines, who has a disease which is very severe, a patient who's on hemodialysis, who have multiple invasive lines, and who has been given quinolones or cephalosporins in the past 3 months. And if you look at the different empirical antimicrobials of choice, depending upon the site of infection, just focus on my cursor in community-acquired infections for SBP, third-generation cephalosporins are the treatment of choice. But mind you, if the patient has a high disease severity, which is defined by CLIF-SOFA score of more than 7, then these patients should be given piperacillin-tazobactam. And this is based on a randomized trial where they compared piperacillin-tazobactam to cephalosporin in patients. Is Chinese trial published in CGS. So they showed that mortality is better if we give piperacillin-tazobactam compared to cephalosporin. Ciprofloxacin oral therapy can be given if the patient is uncomplicated, that is, there is no renal failure, there is no shock, then these patients of SBP can be managed in OPD with the oral quinolones as an empiric treatment. But mind you, the culture has to be sent and appropriate de-escalation or escalation has to be done once the culture reports have come. So this is the empirical treatment antimicrobials of choice. If patient has a nosocomial infection, then carbapenem plus minus gram-positive cover, depending upon the risk factors. For UTIs, ciprofloxacin, cotrimoxazole are commonly used. If the patient have a ceftriaxone allergy, then these patients can also be given broad-spectrum antibiotics in form of ceftriaxone and piperacillin-tazobactam, more so if they have organ failures. Nosocomial onset of UTIs, nitrofurantoin is often used in uncomplicated cases where there is no organ failure. But if the patient has a worsening organ dysfunction or organ failures, then these patients should be given IV systemic antibiotics with meropenem with gram-positive cover. Pneumonias should be covered up with ceftriaxone with a macrolide azithromycin cover. Quinolones we often do not prefer because of risk of tuberculosis in our setup. Piperacillin-tazobactam for patients with organ failure. Patients who have a nosocomial onset of infection, we prefer giving meropenem with plus minus gram-positive cover, depending upon the local epidemiology and depending upon your hospital's epidemiology. I can say of mine that in patients with nosocomial pneumonias in PGI, the carbapenem-resistant infections are more than 65%. Therefore, this becomes a rationale for using colistin combination therapy with either minocycline fosfomycin with nebulized colistin. Skin soft tissue infections needs to be controlled with third-generation cephalosporin with gram-positive cover. Clindamycin is a static antibiotic, should not be used upfront in patients with cirrhosis. This is very, very clear. And in patients who have a nosocomial onset of cellulitis, then the meropenem with gram-positive cover is indicated. Antibiotic infusions, as opposed to a short-term infusion, have a better survival outcome in patients with cirrhosis and infection. And there is a lot of emerging data, which is a consensus-based data only, that double-dose antibiotics in initial 48 hours of shock in patients with cirrhosis and infections can improve the outcome. But again, this needs to be validated in randomized trials. Let's say a patient who comes to us with septic shock and we give broad spectrum antibiotics like meropenem, but the cultures come positive, we de-escalate according to the cultures at 48 to 72 hours. But the patients who do not have culture positivity, then these patients, we can guide our treatment depending on the local epidemiology. But apart from local epidemiology, we can also take help of rectal swabs. And if there is a patient who is a colonizer with multi-drug resistant bacteria, we can target our treatment according to the colonizing bacteria. And recently we also published, it's an accepted publication in Journal of Hepatology Reports, where we showed that most of our cirrhotic patients are colonized with MDRO bacteria 67% of the time in the rectum at admission, and these increase the risk of infection, and the risk of infection is 8-fold higher. And the same bug is present in the colonizing bacteria in around 76% of the time. And if you look at the different, the colonizing strains, if they have more than one colonizing bacteria, they have a very poor survival. Depending upon the culture positivity, we can guide our treatment at 72 hours after the culture reports are available. Patients who have an extended spectrum beta-lactamase producing bacteria, where the bacteria are resistant to third generation cephalosporins, and often at times they are also resistant to piperacillin tazobactam. There the recommended choice is carbapenem. Patients who have infection because of carbapenemase producing bacteria like E. coli and Klebsiella, there the treatment indication, all the guidelines, IDSA, ECMID, every guideline and even the ICMR guidelines recommend ceftazidime avibactam. Patients who have Acinetobacter infection, there the colistin combination with one more antimicrobials is recommended. For MRSA infections, it is the vancomycin and the teicoplanin and daptomycin. And patients who have a VRE infections, again the daptomycin and linezolid is recommended, and tigecycline is also an option. And if we look at the ICMR guidelines for these positive infections, we can see that a lot of emerging bacterial infections in patients in general, as well as in patients with cirrhosis. And if we can detect a particular genotype or which is of bacteria which with the carbapenemase, we can guide our antimicrobials, especially the NDMs, which are the new Delhi metallo-beta-lactamases present in the bacteria. Then we can add aztreonam to these patients, which can improve their outcomes. And if we don't have this combination available, we can use polymyxin with or without tigecycline, minocycline, depending upon the site of infection. Polymyxin should not be used for UTI because it doesn't penetrate. And other OXA and KPC, we can use only ceftazidime avibactam. And if we don't have ceftazidime avibactam, then the second line agents are colistin combination therapy. So this is very important change over the recent past, is that polymyxins and colistins have been recommended as a second line treatment for carbapenem resistant bacteria. And if we look at the Acinetobacter, again, here the recommendations are, apart from colistin, polymyxin, is that high dose sulbactam or cefoperazone sulbactam. One needs to understand that safety of sulbactam in patients with liver failure, especially in higher MELD scores, are not yet achieved. And then Pseudomonas can be treated with ceftazidime with combination of piperacillin tazobactam, and the second line agent is polymyxins. Duration of therapy is very clear. For SBP, it is 5 days. Patients who have a shock, it is near about 10 days. Patient who has a very high inoculum like pneumonias, it is required as 10 days. For patients who have a bloodstream infection, it is 10 days. And for SBP, it is mostly 5 days. Dosages we can consider, and prevention of multi-drug resistant bacterial infections is another topic which is very important, because the mortality of MDROs is more than 70%. So therefore, the stewardship principles for diagnosis as well as treatment is mandated. Antibiotics needs to be used an appropriate dose for an appropriate duration, and unnecessary antimicrobials should be stopped every day. One should consider rechecking the charts of these patients. De-escalation of antibiotics, when every 48 hours we need to reassess. Antibiotic prophylaxis should only be given in selected indications. Patients who present to us with upper GI bleed, they need 5 days of antimicrobial prophylaxis. Patients who come to us with a previous history of SBP, they need to be on norfloxacin prophylaxis. And patients who have a high risk factor for SBP, such as ascitic fluid protein less than 1.5 grams with a high bilirubin and creatinine levels, so these patients require prophylaxis. Otherwise, not all patients of cirrhosis would require a norfloxacin or quinolone prophylaxis. Patients who do not have ascites should not be given the norfloxacin prophylaxis. MDRO carriers can be screened in patients, especially who do not have any culture positivity, and it can help in escalation and de-escalation of antimicrobials. And infection control practices, especially the contact precautions, hand hygiene has to be maintained to prevent a lateral spread of bacteria from one patient to another. A lot of emerging therapies. Regarding the other pillars of management, fluids are important supportive measures for control, maintaining patients of cirrhosis with infections. Crystalloids have been shown to be superior to saline in patients who are in hypotension. 5% albumin has been shown to be superior to saline in patients with sepsis who are cirrhotics, and there they showed that the reversal of hypotension because of use of 5% albumin in patients who are in septic shock is superior with 5% albumin compared to saline. So this has become now a routine care in patients with cirrhosis and sepsis who comes to us with shock, that we use 5% albumin. There is another study which has come up recently in 2022 by Dr. Salim's group itself, that 20% albumin can improve the hypotension in patients with septic shock and cirrhosis. But problem with the 20% albumin is that they have a very high risk of pulmonary complications and pulmonary edema. One can use 20% albumin, but at a very slow rate. The rate given in the study was 0.5 to 1 gram per kg over the span of 3 hours. One can give a slower rate of albumin and can also reverse hypotension in these patients. Vasopressors, initial vasopressor of choice is noradrenaline for all patients with septic shock and patients with cirrhosis. Terlipressin has been used as an upfront comparator for noradrenaline and shown better reversal and decreased risk of AKI, but one needs further studies to confirm this finding that the terlipressin can be used upfront. Appropriate calories are essentially the most important criteria for improving patient's immune system and the improving liver regeneration. These patients have a catabolic state and needs high calories. Omega-3 fatty acid lipid emulsions have been used by again by Albius group, and they showed that the omega-3 fatty acid infusions in addition to enteral nutrition is superior. A lot of data on fungal infections. I'll not go into the details. I'll discuss in the discussion part that how common they are, how to approach these patients with fungal infections. And lastly, I'll give a summary slide on how to manage fungal infections. So one has to consider basically the what are the host factors in a given patient, what are the clinical factors, and what are the biomarkers or the mycological evidence of fungal infection in a given. The clinical suspicion is usually based on the persistence of SIRS despite broad spectrum antibiotics. If there is a biomarker positivity with persistent or worsening organ failures, or if there is a culture positivity of mycological evidence from a given site. Then depending upon the culture positivity from a sterile site, it can be called as definitive treatment for fungal infection. If it is the treatment is given based on the biomarkers and the clinical evidence, then it is a preemptive approach. And if the treatment is given based just on the clinical suspicion, it is called the empirical approach. There is no clear-cut, randomized trial available as of date, which can say that one therapy is superior over another, but one needs to consider that the patient, if it's in shock, then the empiric approach is always superior and improves the outcome, because the early antifungal therapy in a patient with infection, especially fungal infection, improve the outcome. And there one needs to consider what kind of antifungal to give. If you are considering invasive candidiasis, which we often consider in patients who have a persistence of organ dysfunctions without any apparent cause, then we tend to give echinocandins. If we suspect invasive aspergillosis, which we suspect in patients who have a lot of pulmonary infiltrates not improving on broad spectrum antibiotics, they have if they have higher galactomannan levels, then these patients we consider invasive aspergillosis. And here the role of liposomal amphotericin B as an upfront therapy is indicated. Posaconazole as a de-escalation therapy or longer therapy. For mucormycosis, it is there's a syndrome by which mucormycosis present is the rhinoorbital or the sinusitis or the cerebral involvement. And if so, the higher dose of liposomal amphotericin B, 5 to 10 milligram per kg, is recommended for a prolonged duration, along with the surgical management and the resection, which we often cannot do because patients have coagulopathy and a lot of organ failures in patients with cirrhosis. So again, the liposomal amphotericin B is recommended for higher dose, especially in patients with mucormycosis. So take-home messages from this presentation, my friends, are that early identification and prompt institution of antibiotics improve outcomes in infections in patients with cirrhosis. Adequate culture samples has to be taken because most of the times our physician colleagues, junior colleagues don't send adequate ascitic fluid samples or the blood culture samples, 2 sets which is required for diagnosis of infections. Already these patients have a very low inoculum and often we do not diagnose based on the routine cultures. And there are different culture systems also available, such as Bactec system, which has a high sensitivity. But again, you need to send an appropriate quantity and the quality of sample for diagnosing infections. Therefore, we need to be very aware that the adequate sample is very important for diagnosing infections. Starting empirical antibiotics in patients who are worsening and organ failures. Initial resuscitation using surviving sepsis protocol, which we all know, and stop the counterproductive drugs, especially such as PPIs. PPIs have been linked with increased risk of SBP and pneumonias in patients with cirrhosis. One must stop PPI, unnecessary PPI in patients with cirrhosis. Non-steroidal anti-inflammatory drugs increases the risk of AKI. Beta blockers in patients who are hypotensive, patients who have a low MAP, who have a cardiac dysfunction. These patients should not be given beta blockers in an acute state of infection in patients with cirrhosis. And aminoglycosides have a very high risk of AKI, so one must stop these counterproductive drugs in patients with cirrhosis with suspected infection. And de-escalation approach has been shown in observational studies that it is safe, it does not increase mortality, and every 48 to 72 hours, the antimicrobial decisions need to be re-evaluated in patients with cirrhosis, and every 48 to 72 hours must limit the duration of antimicrobials as per the stewardship principles. Finally, I would like to thank Professor Sareen Naak and NAMS and whole my mentors, Professor Duseja, Dr. Chawla, Dr. Singh, Dr. Dhiman, who has, Dr. Sunil, and whole team, Dr. Madhumita, Dr. Arka, Dr. Sahaj, and whole ARC team with the support of whom I am standing here today in front of you to discuss on this topic. And I would love to take questions on this topic. Thank you very much.
Thank you, Nipun. It was really an exhaustive discussion and fantastic lecture. I think you have covered most of the things beautifully. So I think you started off with the pathophysiology and the pathogenesis of infections and the immune responses, and then you took us through the journey of different types of infections. How does the body respond, and then the diagnostic strategies, and finally the treatment strategies involving the different types of infections, including the multi-drug resistant organisms and the fungal infections. Of course, we understand that 1 hour is too short a time to discuss infections in cirrhosis, and you have really done it very well. So I must congratulate you for that. It's a fantastic job, Nipun.
Thank you. Thank you.
So I'll start off with some questions which I thought that, which would be of interest to the postgraduates and people in practice. And some of the things, of course, for want of time, you could not cover in detail. But let's start with the fungal infections, which you discussed. So, one of the commonest challenges is timely diagnosis of fungal infections. And we do have some biomarkers like beta-D-glucan and galactomannan. So my question to you is, what is the reliability of BDG and galactomannan in the blood and in the bowel fluid? So what will be your cutoff values, and when do you say, okay, this is sufficient enough for me to start therapy?
Thank you very much, sir, for the kind words and the questions. We all agree that diagnosing fungal infections in patients with cirrhosis is difficult. Why? Because these patients have atypical signs and symptoms, and we have a poor reliance on biomarkers. We don't have enough literature on biomarkers. So starting off with these facts, the patients, we don't treat biomarkers. For all the students, one must consider that we don't treat biomarkers. We don't treat biomarker beta-D-glucan. We treat patients. So patients needs to be stratified depending upon their host, clinical and biomarkers or mycological evidence. The host factors are very important. Any patient in ACLF is itself a risk factor. A patient who's in ICU is a risk factor. So any one host factor, then the clinical factor has to be there for treatment. Clinical factors include, and this is more so for Candida and Aspergillus, not for mucormycosis. Patients may not mount features or symptoms or signs suggestive of mucormycosis. So I'm keeping mucor different. So invasive Candida and Aspergillus, one must consider that the patient should be clinically symptomatic for fungal infection. When do we consider fungal infection? We go by algorithm. We treat bacterial infections first. We see their 48 to 72 hours, they are not responding. And these are the group of patients who are not responding. We tend to consider fungal infection. Now you can debate on what are the criteria when we can say that the patient is not responding. For a consensus opinion worldwide, it is defined that a patient who's in hospital on local epidemiology based antimicrobials for more than 72 hours and not showing improvement in organ failures is something a clinical syndrome of Candida infection. So a patient who is not responding for 72 hours, this is a syndrome of Candida infection in terms of SIRS and worsening of organ failures. Then apart from this clinical factor, if the patient shows a beta D glucan levels, which is above a particular cutoff, and the cutoff again you can decide depending upon their sensitivity and specificity, the higher the cutoff, the higher the likelihood. The problem with beta D glucan is that it is false positive because of many conditions. So one must consider and rule out false positives. And if false positives are not there,
antibiotics. Especially the use of antibiotics. That's a very common thing which will cause.
So I would say that, if so, I have a lot of, things in my mind. So one important thing is very high positivity beyond 500. It is very highly specific, more than 100% specific, shown in multiple studies in general medical population, and in cirrhotics, one study also shows. So 500 and above, clear-cut likelihood of infection. Patient who has a positivity of beyond 150, the probability is close to 55 to 60% post-test probability, we can say. If the titers are rising on 2 occasions, then again the risk of infection is very high. But if a patient has a less than 80, it has a very high negative predictive value in a patient who has a ongoing fever, ongoing sepsis, ongoing SIRS, because and patient still on broad spectrum antibiotic like meropenem. And if the patient has a beta D glucan of less than 80, then it has got more than 90% negative predictive value. This is in general medical population literature, which is I'm talking about, because in cirrhotics only 2 or 3 studies are there. One of our studies we showed that it can be used, but the problem is very extreme and it is very clear. In between, it is doubtful, and there the clinical as well as history, the risk factor and the clinical factor has to be taken into account, and the increasing titers have to be taken into account for treating Candida. For Aspergillus, sir, I think the very important fact is that the cutoffs, again 1.5 and above, very specific, more than 80% specificity. A patient who has a cutoff less than 0.5, again extremely well, you can stop or need not to treat such patients. Patients who have a 0.5 to 1.5, what to do in these patients? So in these patients, we do this PNS screening as well as HRCT chest, and any lesion suspected of aspergillosis we tend to treat. So BAL versus the multiple systematic reviews in general medical literature has been shown that the cutoff of 1 and 0.5 respectively for BAL and for serum has a balanced sensitivity and specificity, balanced AUC levels for the diagnosing invasive aspergillosis. But again, this is debatable. I would say a lot of data has to be generated in cirrhotic population. Our patients behave differently. So here the art and science both has to come for treatment of patients. There is no clear answer to this question.
Yeah, thank you so much, Nipun. I completely agree with you. There's so many challenges while interpreting these biomarkers, and as you very appropriately said, we cannot depend on these biomarkers alone. They have
Yes.
to take interpreted in terms of the clinical context and the radiological findings. And of course, they can be confirmed later on with the culture. But we all know that the fungal cultures take a longer time, and therefore, very often we have to depend on the clinical interpretation combined with the biomarkers to take clinical decisions of ruling in or ruling out fungal infections. So I think that's a reality which we cannot run. And as you said, it is more of a art than a science as of now. But it is something which has got a good scientific basis, and therefore, over a period of time, we would, once you start seeing patients, you get a hang of it, how to interpret it clinically. The next question which I had, again, since we have started with the fungal, is, we have a definite problem of invasive aspergillosis in cirrhotic patients. So how do you take a decision about which drug to start? Because now you have isavuconazole on one hand, which is pretty hepatosafe and easy to give. You have a tablet form also. And on the other hand, you also have posaconazole and amphotericin B. So how do you really approach in your practice which drug to give?
So regarding the drugs, PKPDs are very important for managing a patient with antifungals, more so in cirrhotics. Patients who are having shock in multi-organ failures, that the antimicrobials, which is clearly defined, is a first-line drug is voriconazole for invasive aspergillosis. The problem is voriconazole in a patient with cirrhosis, with organ failure and poor liver dysfunction, is that it leads to higher rates of hepatotoxicity, drug-drug interactions, and most of the physicians are not comfortable in giving it. Although there are multiple studies showing that you can use half the dose, you can 1/4 the dose, whatever, but you need to do a therapeutic drug monitoring. So it is completely out, which is the first line drug as per the recommendations in general medical population. Now comes the second line drug. The second line drug is the liposomal amphotericin B. Liposomal amphotericin B is used upfront in such patients as of our center, because these patients who are in organ failures, who are in organ dysfunction, they have a deranged pharmacokinetics of, the distribution of antifungals is deranged in these patients, and studies have shown that the penetration is decreased in pulmonary fluids because of amphotericin, because of third spacing, because of so we need to have a increased pulmonary concentrations of liposomal amphotericin B, so which is decreased in patients with cirrhosis because of third spacing, because of ascites, because of edema, a lot of other things, because of collateralization. So therefore, liposomal amphotericin B is recommended for such patients. But the problem of liposomal amphotericin B is that it can increase the risk of AKI, and although there is no recommendation to reduce the dose in patients with AKI, we tend to continue with the same dose, but the AKI and the patient progressing on to hemodialysis is very high. Isavuconazole is something which is come up in the market and now available in the lower cost also. And generally posaconazole and isavuconazole, they are given as a de-escalation therapies after the initial organ dysfunctions are controlled. So therefore, the recommendations, the consensus-based recommendations in cirrhosis, which whatever the ID experts say, is that give liposomal amphotericin, patients get controlled, then shift over to posaconazole or isavu. Isavu doesn't merit any TDM, but posaconazole in child C cirrhotics merit therapeutic drug monitoring. So the answer clear is, what we use is, if patient is diagnosed to have invasive aspergillosis, we give liposomal amphotericin B. Patient is if developing organ failure such as renal failure, going on to dialysis, we shift over to posaconazole. But isavuconazole needs obviously studies in our group of patients.
Thank you, Nipun. That was a good detailed answer. I think I'm sure the post-graduates would have benefited. The clear message is liposomal amphotericin B would remain one of the drugs of choice in this situation, especially when we are not very comfortable using voriconazole, but isavuconazole is a good emerging option, which is quite effective. Now, one more problem which we are facing clinically is the Candida auris. And, colonization with Candida auris is very common in our cirrhotic patients.
Yeah.
And when these patients go for transplant, you're always worried. So how do you approach a patient who is on the waiting list and, you take a swab and he comes as Candida auris positive, let's say axillary swab?
So, this is really a tough question because Candida auris colonization is a superbug actually, and it is resistant to most of the antifungals. And but let me tell you, the problem with Candida auris is that it is the geography also, which is very important. There are different clades in Candida auris, and the South Asian clade, which we see in our setup in India, is fortunately sensitive enough to echinocandins. A patient can be given echinocandin depending upon the risk factor. This patient has a transplant which is being planned, and more so in LDLT, more so in gastroenteric anastomosis, these patients are at very high risk of Candida infection. So their empiric, I'm saying not even empiric, prophylactic antifungals are recommended. Prophylactic, I mean that their patient has not yet developed any sign and symptom of infection. Empiric means patient has developed sign and symptom of infection. So Candida colonization is a risk factor. It is not a criteria for infection. So a patient individualized approach has to be taken definitely. But a patient who is already at a very high risk of Candida infection post-transplant, in our setup at least, we tend to give antifungals who are at high risk. So Candida colonization is a risk factor. Therefore, these patients and
would receive a echinocandin during the post-transplant prophylaxis.
During the post-transplant and peri-transplant period, yes.
Perfect. Absolutely. I think that was a very important point which you highlighted. I think we had enough discussion on fungal. Let's go to something preventive. So, Nipun, there are different societies which have given different recommendations for vaccinations in cirrhotic patients. So, what do you think should be the approach in India according to our prevalence with regards to vaccination, other than the hepatitis A, B vaccination that I think is enough and everybody is aware of it? But other infections, what all vaccinations would you advise to an adult cirrhotic?
So, Dr. Akash, I think, again, the literature is not very clear, but although in patients who are posted for liver transplant, at least, we have a panel of, vaccination which needs to be given, and pneumococcal vaccine is amongst one of them for prevention of pneumococcal infections. But you hardly have any other, pneumococcal is predominantly they cause pneumonia when they cause SBPs. So, okay, that's okay. Pneumococcal vaccination can be given. Live vaccinations are avoided because of immunosuppression. So, I don't think there is any strong evidence apart from this for other MDRO infections or any other vaccinations.
Yeah, I agree. So there is no vaccine for the MDRO infections, but some of the societies would recommend, for influenza, also for pneumococcal, as you very appropriately said, both the 13 and the 23 valency ones. In addition, we can also think of Tdap. Some of the societies have talked of Tdap in adults. So I think there are some options, but as you very said, there's not much evidence to support. And these are again gray areas, but we have to keep these in that these are the options that we really have with us when we look at our adult patients with cirrhosis, especially decompensated cirrhosis. And as you very rightly said, the response rate in them is lower as compared to the general population. And therefore, the efficacy may not match that of the healthy population. So these are the things which we have to keep in mind. One more practical question which we face is choosing between polymyxin B and colistin.
Yeah.
So I know that there are no black and white answers to this, but and there are people who are polymyxin B believers and there are people who are colistin believers, and we know the difference that there's slightly more neurotoxicity with colistin, lesser with polymyxin, and same with renal. So what is your take? How do you choose between colistin and polymyxin B?
So let me tell you, sir, for the students, the guidelines say, ICMR as well as ACMIT guidelines, patients who have a UTI, urinary tract infections, their polymyxin should not be used. Polymyxin do not penetrate the urinary tract. So colistin is the answer. Even if the patient has a renal failure, you modify the dose because the concentrations do not reach. Second, patient who has a preserved renal function, then colistin obviously is preferred for interabdominal infections. Patients who have a deranged renal dysfunction, but a site of infection apart from UTI, I tend to prefer polymyxin B because it has got a better renal safety. And of the late, we have used thousands of thousands, I mean, at least hundreds of patients we have used both colistin and polymyxin. We have seen that polymyxin dose need not to be modified in patients with renal failure. There is no worsening of renal failure. Patients can be given nebulized polymyxin B also. So I think polymyxin is generally preferred, I would say, and in UTIs, colistin is the preferred. That's the how we choose it, at least.
Great, thank you. Another issue which we face very commonly is the question of giving primary prophylaxis for spontaneous bacterial peritonitis. And given the resistance that we are seeing to fluoroquinolones in the community, so do you think it is time to relook at the strategy and whether we should continue with the same? Is the dose adequate, or should we look at the change in the drug which we are using for primary prophylaxis?
Very rightly, sir. I was also bugged over the last 4 years. I have been thinking, and we are planning something on this. So primary prophylaxis is going. So prophylaxis has a 3 levels of indication in cirrhosis. One, upper GI bleed, which is very clear. 5 days of prophylaxis decreases the risk of SBP in patients who have upper GI bleed. That is clear, but it does not increase the risk of SBP. Patients on secondary prophylaxis, let's say patient who has developed an SBP episode and has a ascites which is continuous, and patient need secondary prophylaxis for SBP, and there we give quinolone prophylaxis, and it can increase the risk of MDRO also, but it is indicated because it decreases the risk of SBP, it reduces the mortality also. A group of patients who are on primary prophylaxis where the ascitic fluid protein counts is less than 1.5 grams and a high disease severity. So these patients given for long-term antimicrobial prophylaxis, there clearly it has been shown, recent study from Dr. Jasmine Bajaj also showed increased risk of the multi-drug resistant bacterial infections. So definitely it has to be relooked. The answer is not clear. The guidelines are not yet clear, but my perception is that we individualize in each patient. If the patient has a very high disease severity, we give it. If a patient, like say for an example, Dr. Anand Kulkarni's studies recently has shown that patients with ACLF given norfloxacin prophylaxis with ascites can improve their outcomes, can improve their mortality. So again, the idea is patient is severe and patient has a very low protein count, then probably it can be helpful, not all patients. And obviously the risk of MDRO is increased. We also showed that the colonization with MDRO increases after norfloxacin prophylaxis, and it's a independent risk factor for colonization by MDRO, 3.4 times higher risk of MDRO colonization. But to translate into clinical practice, we need to have a risk benefit ratio assessment, and
Correct.
that needs to be assessed in further studies.
Absolutely. So I agree with you, Nipun, on that there are certain situations where you would definitely want to give prophylaxis, in especially a very sick patient, somebody who is predisposed, you have risk factors. I think those are the patients where you would give. We also know that the benefits of norfloxacin probably extend beyond just their antibiotic role, improving the gap junctions of the resistant epithelium and improving the robustness of the innate immunity. So I think those are some of the additional benefits that you get, and which you only with norfloxacin and not with some other antibiotics. Nipun, we still have a few more minutes, so I'll keep on bothering you with some more questions if you don't mind. So one of the other things is, we have a lot of use of rifaximin now. In fact, in addition to encephalopathy, I find a lot of patients being put on rifaximin even in the absence of the usual indications for soft indications. Do you think this can predispose people to drug-resistant infections in the future or resistance to rifampicin in the future, although there is no current evidence to support that this is true?
So I would give an evidence-based answer to this. A study on resistome, gut resistome, was published by Dr. Bajaj in, I think, gastroenterology. There they showed that the use of rifaximin was not at all associated with increase in resistome, or if we take collective genes which is causing resistance, antimicrobial resistance in the bacteria, and if we see that patients who are using rifaximin versus who are not using rifaximin, so there was no increased resistome quantity in patients with cirrhosis. So as of now, no evidence to suggest that it increases the risk of MDRO. Second, there can be a resistance to rifaximin per se in long-term use, and that is an apprehension. RPOB and some genes are there for, RPOB is the gene basically, which can be acquired. But as of now, rifaximin long-term use has not been associated with risk of MDRO infections. Does not affect.
Yeah.
I mean,
So
there is no positive or negative, it doesn't affect.
Yeah, so that is the data, as you very rightly said. So far, no data shows that there is a long-term resistance concerns, but there are skeptics who keep on raising these issues. So I thought the PGs need to know this.
Rather, sir, there is a question that what would happen if you use rifaximin and norfloxacin together? This thing has not been addressed, and it's not yet clear. So a lot of research which can be done, a lot of things can be done. So all the MD students, I would encourage, get into area of cirrhosis, get into the area of infection, because patients are dying day in and out, and one must do something for these patients.
So one more common situation is the the diarrhea, and so very often you have your cirrhotics who come in with diarrhea. And this may be 1 day, 2 day duration of diarrhea. Now, two questions which I want to ask. One is, when do you decide to start antibiotics? Assuming that we are not talking of SBP associated diarrhea, but this is true luminal diarrhea. And the second question is, do you ever use stool biofire in your routine clinical practice?
So see, sir, the difference between a private or a corporate setup and a government setup is that we work with the limited resources. So it's good because, biofire gives you a panel of bacteria and viruses. So, and you end up looking here and there, what to treat, what not to treat. Patient is improving. So I would say, sir, patients who have diarrhea, first and foremost for all MD residents, rule out SBP. That is most important. Second, if there is no SBP, so again, the problem of SBP diagnosis is not very clear, sir. Patient who has received 1 or 2 doses of antibiotics, there the ANC levels, the TLC counts decrease. So one must consider a symptom as a whole. A patient who has a pain abdomen and diarrhea with the ANC count of hovering around 200, this is an SBP. This is very clear, right? So treat for SBP. Let's say we have ruled out SBP, there are less than 50 cells, it is not an SBP, diarrhea. Now the diarrhea is, if the patient has a systemic sign and symptoms, I do treat with them antibacterials, right? For Clostridium difficile in hospital, patient who has a diarrhea in hospital, we check C. difficile and treat for C. difficile if it is positive using their C. difficile toxin assay. Regarding other travelers diarrhea and other stuff, I think we need to do stool RE and cultures if the patient is not responding 48 hours to the conventional oral therapies.
Thank you, Nipun. So we have a question from the audience. Dr. Sirigiri Hari is asking that you have a patient with high protein ascites with lymphocyte predominant ascites and elevated AD of 54, negative for CBNAT and cytology. In such a case, would you start empirical ATT, assuming that there is no other evidence of tuberculosis elsewhere in the body?
So I would say yes, because our study also, Dr. Sunil Taneja and our group, we did a study and we found that a cutoff of 25 or 26 was very good in ruling in the diagnosis of tuberculosis in cirrhosis. One must treat them empirically if they don't have the CB-net positivity. ADA levels are fairly enough, good enough.
Yeah, and CB-net anyway has got a very low sensitivity
Low
for
sensitivity.
in patients with ascites. So excellent. Thank you, Nipun, for that answer. One more question which I had was, we are facing a lot of patients with NDM, OXA48, carba resistance. So these are a reality. So what habits would you want the residents to inculcate so that as a society, as a group, we can prevent the escalation of these bugs, and also we prevent our, basically we can sacrifice a few patients in the larger interest of a bigger cohort of patients. So your thoughts on that?
So I would say, sir, for all MD resident, my colleagues, actually, that antimicrobial stewardship is the key to prevent multi-drug resistant organisms and their infections. Let's say, so do not start antimicrobials unnecessarily. Stop antimicrobials when they are not indicated. Do not use unnecessary antimicrobial prophylaxis. Second, maintain hand hygiene, because there is a lateral spread of these MDRO bugs. These superbugs are actually transferred from hospital environment. So never keep your belongings or never keep, at the patient bedside. Always keep your files and trolleys away from the patient. So before entering the patient area, after leaving the patient area, before touching the tubings, after touching the tubings, one must do hand hygiene, proper hand hygiene. Third important thing is the education. Aapne patient relatives and sanitary attendants of the patients are the key players which transmit infection from one person to another. The cleanliness of the patient is highly important. Okay, but once they clean the patient, they take their belongings from one patient area to the another patient area and to the gowns, and then they transfer these MDR bacteria. Third is the nursing. Fourth is the nursing. These nursing, people, what they do is they do the suctioning, and they don't change the gloves. And handling of lines is very important by nursing. So nursing care, appropriate hand hygiene, antimicrobial stewardship, good nutrition. Good nutrition would prevent the acquisition. The tolerance, I mentioned about the concept of tolerance. Tolerance comes from poor sarcopenia. The deranged tolerance to infection comes from the sarcopenia. So patients need appropriate nutrition. So maintain their nutrition. So these are the key principles: education of relatives, education of sanitary attendants, hand hygiene, nursing care, and antimicrobial stewardship are the key pillars of the prevention and treatment of MDRs.
Thank you, Nipun, so much. I think the last thing that I would take before I hand over to you would be the discussion on no infection discussion in India would be complete unless we discuss mycobacteria and non-mycobacterial tuberculosis. So one of the common problems that we face is treatment of a TB, of mycobacterial tuberculosis infection in patients who have got decompensated cirrhosis. On one hand, we find patients being put on the standard ATT by some, and on the other hand, we find some of the gastroenterologists or hepatologists starting these patients on absolutely no hepatotoxic drug. So, and we know that there is no very good evidence to support any of the strategies. So what will be your take-home message for the residents in treating tuberculosis? And we're talking of mycobacterium tuberculosis right now in patients with decompensated cirrhosis.
I would say they should consider reading a nasal paper on this, and Dr. Dhiman was the author, and we showed actually that according to CTP class, one can use the anti-tubercular drugs. Patient who has a child C cirrhosis, no ATT, no hepatotoxic ATT at all, and the duration of treatment is 18 to 24 months, and the hepatotoxic ATT are isoniazid, rifampicin, and pyrazinamide. Patient who has a child B cirrhosis with tubercular infection, then one hepatotoxic drug, and one can debate whether to give rifampicin or isoniazid. We prefer to give rifampicin, sometimes isoniazid, but I think rifampicin is one we often use along with ethambutol and levofloxacin for 9 to 18 months. And for patients with child A cirrhosis, 2 hepatotoxic drugs, isoniazid and rifampicin, along with ethambutol and levofloxacin. Now the question is when to add this streptomycin or amikacin in addition to, and add further second line or third line drugs. So this is tailored according to the individual practices and by the individual choices. We in PGI we tend to give amikacin in IV injections because sarcopenia hota hai and the coagulopathy is there, so we tend not to give streptomycin intramuscular injections in patients who have a higher inoculum or a disseminated infection. Higher inoculum means CNS infection or who has a disseminated infection. So we prefer to give a patient who is stable, just tubercular lymphadenitis. There we can also give 2 drugs, but this is tailored according to the patient. So 3 drugs usually in child C: ethambutol, levofloxacin, and amikacin if the patient's inoculum is high. Yeah. Right? I think I'm clear on that. I think.
Yeah. So usually pyrazinamide is something which all of us would keep away from in all patients, and then depending on the child pug status, you decide to give 1, 2, or 3 hepatotoxic drugs. And again, like Nipun said, there is no clear evidence, but this is what is the general consensus that is there amongst many of the gastroenterologists, that in child C cirrhosis, we would avoid using any hepatotoxic drugs. The rationale being these patients may not be able to tolerate a hepatotoxic event, and therefore the decompensation can be fatal. Whereas patients with child's B cirrhosis, you can probably start 1 hepatotoxic drug, and usually you will get away with it, rifampicin or isoniazid. And in child A cirrhosis, you can use probably 2 hepatotoxic drugs, and pyrazinamide is something which most of us would avoid using. I think we have finished our time, Nipun. Thank you very much for all the question and answers. I will now hand over back to you for assessment of the audience. So over to you and back to you, Nipun.
So we have a limited set of students here. So anyone wants to ask any question, feel free to discuss and ask the questions, because day in and out we see such patients of infections and difficult situations oftentimes.
I can see Dr. Nitish is there. Nitish Patwardhan, you can ask. Dr. Habib is there.
So I am supposed to ask them questions?
I don't know. It's supposed to be your assessment of them.
I think they all are completely overwhelmed with the infections. Anybody wants to ask any question? It's an open discussion, I think. No, I think.
Sir, like usually it is the assessment of the participants. If you'd like to ask any questions to them to find out what they have gained. So if you would like to ask.
I think it's okay.
I see. Sir. So I would now like to, sir, then shall we conclude, sir? I'll invite Dr. Ajay Sood, sir.
Yes, sure.
Thank you, sir. Now that I would like to invite Professor Ajay Kumar Sood, sir, to provide the vote of thanks.
Thank you so much. It is indeed my great pleasure to thank the team's expert for this evening. I know both of you are from very premier institution. Your time is very valuable. We are really grateful to you for sharing your time with our PG student. I'm sure that our students have greatly benefited from this interaction. In fact, your presence itself is a source of encouragement for many of our students. So thank you so much, sir. Special thanks to Dr. Nipun Verma for taking another interesting session for our student, giving practical tips from practical point of view as well as for the examination. Thank you so much, sir, and we look forward for your support in future also. And our great thanks to Professor Akash Shukla, sir, for sparing your valuable time and generating a lot of discussion. I'm sure the type of question which I've asked will be very useful for our PG student, not only for their practical, but also from the examination point of view. So thank you so much, sir. And we look forward for your blessing in future also. And again, I would like to thank the Chief Coordinator, Professor Ajit D'Souza, sir, for coordinating this interesting series, selecting the best expert, and also selecting the best topics for our PG students. We are really grateful to you for your support to academy. Again, I want to make an appeal to our students because many of the students are requesting us to issue certificate. So I will request the student that when you log in for this Zoom meeting, please log in with the name with which you have registered with us. So that will help us in keeping track, and that will help us in sending you the attendance certificate. And once again, I will request all the PG students that they should take the best use of this opportunity, because it is very rare that you are able to get an opportunity where you can directly interact with the best eminent speakers in the country. So you can always send us question in advance, we can put to the speaker, or during this session, question answer session, you please ask your questions and share and get the benefit from the experts. So in the end, I will like to thank Dr. Preeti, who has been helping us throughout right from January 2023 when we started this Navigate program for organizing this. So thank you so much for your support. And our IT team here, Mr. Ravi and Mr. Anil, who have been helping us. So with these words, I thank you all. And just to remind you that the next session, which we have on 16th of May, again, there's a very interesting topic, an update on how to manage acute liver failure. So I invite all the participants, all the students, and I request you please encourage your fellow colleagues and other students to join this very interesting session on 16th May, which is acute liver failure, but is the latest update in the field of medicine. So with these words, I would like to thank all of you once again, and good night. Thank you very much, sir.
Thank you, sir. Thank you, dear all. I declare today's academic session closed.